In this module, we are focusing on ethnicity and immigration. For this module's readings, article readings, you've learned or were reminded based on your knowledge in terms of ethnicity immigrations as determinants of health, how they can, these characteristics, these social characteristics, can impact health and mental health. And these conversations have also been taking place in the media over the past few years, more so in the past 8 years, as conversations about immigration and immigration's policies have been much more prevalent than before. So let's delve into looking at immigration, ethnicity, immigration, health, and also we'll look at the interactions of ethnicity, immigration, on health, which is what this lecture is much more focused on. So a reminder of ethnicity, its definition, social and cultural characteristic backgrounds or experiences shared by a group of people. And these include language, religion, beliefs, and barriers. And these things can be handed down from generation to generation. Immigrant is defined by the CDC as a foreign-born person traveling to the United States on an official immigrant visa. And again, we just focus on we're saying in the U.S., but to any host country that is where the person is not native of. As I mentioned earlier, both ethnicity and immigration status have shown to be important determinants of health because of the various factors that are associated with these characteristics. So immigrant population account for almost 14% of the U.S. population, and most immigrants they're native of Latin America, and among Latin America, most folks originate from Mexico. The most recent report that was actually published in 2014 showed life expectancy for Hispanics, which include both non-immigrant and U.S.-born Hispanics, was almost 82 years in comparison to that of whites. Some studies have shown that Mexican Americans, for example, have lower rates of certain conditions, including heart disease and cancer, in comparison to whites. So overall, life expectancy in some disease conditions, some studies have shown, including surveillance data in terms of life expectancy, assessment of condition of disease in terms of prevalence rates of disease among Hispanics or between Hispanics and other racial groups, have shown overall Hispanic tend to fare better than the other groups. The Hispanic health paradox is based overall in this sort of paradoxical frame that even though Hispanic Americans have shown to have to be of low SES and suffer from poverty in comparison, for example, to whites, they tend to have better health for some disease conditions and higher life expectancy, which we just shown in previous slide, in comparison to their white counterparts. For example, Mexican Americans have shown to have low mortality rate for all associated conditions. For example, for all the major conditions typically that are impacted with high mortality rate, their studies have shown that Mexicans tend to have lowest mortality rate. And this is based on morbidity and mortality data. And one of the criticism or limitation of that type of data is that there has been question in terms of accuracy of the data, in terms of with the possibility that Hispanic at times can be misclassified. So in terms of the accuracy of the data, with potential for misclassification, or evidence of misclassification, it might be that there's an underestimate of mortality rates among Hispanics, including Mexicans, for certain conditions. So the one of the studies by Crimmins et al. Look at was a national survey from 1999 to 2002. A sample size of 4,206 participants, and they were looking at biological mechanism or biological markers for certain chronic disease conditions. And what they looked at were blood pressure, metabolic profiles, inflammatory risk profiles. And they found that one of the results that they found, they report, is that U.S.-born Americans still had higher biological risk than whites, also than foreign-born Americans. So the Hispanic health paradox does not hold weight for these biological risk profiles. So this is an evidence to the contrary, that despite having low SES, despite being in economic hardship, almost that as Hispanic identity or your ethnic identity might be a protective factor. Hispanics, including Mexicans, Mexican Americans. And I have to say that these type of studies tend to oftentimes do not differentiate between Hispanic, U.S.-born Hispanics, or Mexican Americans, or Mexican-born Americans, because folks can be naturalized and still be identified Mexican American. So, of course, few studies, including those being reported here, show that Mexican Americans tend to have high rates of diabetes, kidney disease, as well as liver disease than non-Hispanic population. And several studies have shown that the prevalence rates for various serious conditions that are associated with early mortality among Hispanics, including immigrant subgroups. The immigrant health paradox also does not hold weight. So the immigrant health paradox is very similar to the Hispanic health paradox, basically showing that several studies have shown that immigrants tend to report better health than their non-U.S. born peers, despite, in spite of various economic hardship, including poverty. So for a comparison, studies show that compared to foreign-born Hispanics, U.S.-born Hispanic had a 22 higher risk for diabetes, 15% higher risk of chronic kidney disease, and 42% higher risk of asthma. So there's a slight difference in terms of looking at the health paradox box for, let's say, Hispanics overall, saying that despite these conditions, really hardship conditions, they tend to have better health, and as I mentioned, life expectancy and certain low prevalence of certain conditions among these populations are some of the evidence that are used to support that. These patterns, and several studies have shown these patterns to support that. And similarly, with immigrant health, a lot of assessment studies, which tend to be assessment studies looking at prevalence of disease rates among this population, they tend to report better health in comparison to their U.S.-born counterparts. In these type of, while we are focusing on Hispanics, immigrants, these type of statistics can be relevant for other non-born immigrant groups in comparison to the U.S.-born counterparts, peers. So there is established literature that looking at prevalences rates of certain conditions or biomarkers that serve as risk factors for certain conditions, they tend to be, the biomarkers that are risk factors for certain conditions tend to be low among immigrant populations. Although the differences may change over time, between the two groups may change over time. So basically, yes, the differences can dissipate over time, and some of the explanation for the differences in biomarkers, for example, or the differences in self-reported health between those populations, one of the explanation is that the increased risk for depression and anxiety that are relevant among immigrant groups. So chronic stress, underlined by so many different factors, which we'll go over in a minute, place folks, as you know from previous lectures and previous readings, chronic stress are risk factors for various for developing various chronic conditions that play a role in terms of disparities you may see among different populations. Here are some of the many chronic conditions that are prevalent among Hispanics, and that include immigrant populations. So obesity, diabetes, particularly diabetes, type 2 diabetes, very prevalent among Hispanic populations, high blood pressure, cancer, stroke. In Alzheimer's disease. Alzheimer's disease, there is genetic components to it although we may see the differences among Hispanic or in whites, there might be other factors that might be explaining it in addition to social determinants of health. Disparities among Hispanic populations, including immigrant population, recent report of mortality rates, infant mortality rates, also are impacting this population as well. So this is a within comparison group in terms of different Hispanic subgroups. For Cubans, 3.8 deaths for 1,000 live births. Puerto Ricans fare a worse, 5.6 deaths for 1,000 live births. And in comparison to white, infant mortality is 20% greater among Puerto Rican, based on a report by the CDC. In 2020, report by Statista, which is a statistical platform that really track different mortality rates, other health behaviors among different populations, show that among Hispanic population, the death rate was 98.6 per 100,000 of the population. And the increase of death rates was likely attributed, at least partially contributed, to COVID-19. But COVID-19, as you know, really helped bring the focus on various determinants of health for this population. So disadvantaged economic circumstances of Hispanics, including U.S.-born population, increased risk for so many chronic conditions. And some of these circumstances are low level of employment, low level of education, higher poverty rates, and lack of access to quality care. So why might be relevant to the high death rates that you see with COVID-19? Well, if you're doing low level of employment, you might be more in the front line, so we're increasing your risk of being exposed to COVID-19. Low level of education go into the type of employment opportunities that you have, and being high poverty rates plays into the type or lack of access to quality care for both preventative and management of disease conditions. Factors associated with disparities or health inequities among immigrant populations are similar to those we see across different populations, for example, different racial group and between men and women and different sexual minorities. So education, employment, workplace condition, income. However, the underlying mechanism, underlying issues, inequities that really support the disparity in education and employment or income we see among immigrants, certain immigrant populations, may differ because of immigration status. So they present in unique ways for a certain population. So poverty accounts for lack of health care access among, for example, let's say U.S.-born Hispanic, but also for foreign-born Hispanics. However, for the foreign-born Hispanics, especially those without an legal immigration status, immigration status plays a role in lack of access to care. So there are unique factors based on immigration status. Chronic stress associated with discrimination or poverty plays also an important role in disease conditions that you see in both, for example, U.S.-born Hispanic and foreign-born Hispanic. And then within that, you have subgroups of Hispanics, whether or not within foreign-born Hispanics, you have some subgroups, whether or not these folks have legal immigration status, because immigration status plays a role in terms of access, public health, access to public services. So foreign-born subgroups, immigration status, because of lack of immigration status, they may have very, very little opportunity for employment. So employment is influenced by different factors among immigrant groups. So strategies for addressing health inequities among immigrant populations. So, and these are across various studies, anti-immigration policies. So at the federal level, there are policies that really have puts various structures in place that serve as hindrances to public health services that are really important to allow folks to have access to health care, access to food, and some policies that have been enacted, including that of 2019 for example, for some reason his name is under the Trump administration, have shown to really impact immigrants, because basically if you're an immigrant person thinking about obtaining permanent legal residence, if you are in need of these services, that may make you ineligible for obtaining legal residence, which is absolutely a huge hindrance by being able to access resources that folks need. So looking at anti-immigration policies that really further underserve the already underserved is really important. What are some certain policies that really make it hard for these populations to access services that could really address disparities in health? Barriers to health services, even when policies are enacted in a way that is shown to protect immigrant population in one aspect, it also could hinder them in another aspect. Like, for example, DACA allow access to education for folks who may not have immigrant legal status. However, they still cannot access Medicaid. So also at the state level, depending on the states you live in, and we know some of the states, though I would not mention them, some of the southern states, stop and show me your papers, especially during the Trump administration. I'm not saying that was not effective. Some aspect of it was not being used during the previous administration, including the Obama administration. But it was much more so brazen during Trump administration that people were being stopped just because they look Hispanic or look Mexican, quote unquote Mexican, and show me your papers. So at the state level, we see that a lot of different business owners were being punished for hiring immigrants without legal status. And also within that certain state, certain services are limited for folks without legal status. So we see that barriers at the federal and state level really help to support inequities in health. And these inequities in health show up to increase vulnerability to various chronic conditions. So in terms of our work, how we work with folks that are from immigrant background, we also have to be aware of subgroups of immigrants from whom there are certain different barriers that are barriers to health, and part of the essential factor in terms of those barriers to health, to accessing healthcare or various programs that allow you to increase access to nutrition. Unfortunately, legal status is one of the is a main factor that we have to be aware of when we're working for immigrant populations. And again, immigrant population, there are some populations for whom this is an important factor. And this is really essential in terms of folks that help with accessing resources within the hospital, wherever you work, and you have to be aware how immigrant status may really should influence the type of information in terms of available resources within a community for this population. Because I have worked with patients for whom they've gotten a list of resources from social services, only to find out most of these services they're not qualified to receive any of the services because of their immigration status. Economic exploitation is one of the important factors that has to be addressed in order to really look at inequities in health, inequities rather that are supporting or increasing risk for various health conditions among immigrant populations. Economic exploitation is not just relevant for immigrant subgroups for whom that legal status is an issue, not having legal status. Various studies show that this is relevant for immigrant populations, since comparison to U.S. born, they tend to have jobs of low wages, working in really poor working condition, and discrimination in the workplace in terms of promotion tend to go to U.S. born in comparison to those who are not U.S. born but do the same work or even perform better. In time, immigrant sentiments among certain subgroup of Americans, this ridiculous sentiments that immigrants are taking folks' jobs, also lead to employment, economic exploitation. In a sense, I think of a situation wherein you are within a state where the sentiments is pretty prevalent. And unfortunately, a lot of southern states, you see that. And in comparison to New York or to Massachusetts, where you see that anti-immigrant sentiments is pretty high. So folks who are at a job within a state, who are working in a job where there is deplorable working condition, there is discrimination, they're less likely to speak up because, first of all, they don't want to lose their job because there's not really support within the community, within that state for them. And also, retaliation of deportation is one tool that some supervisors use to keep immigrant populations in place, especially those, of course, more prevalent for those for whom this is an issue. Legal status is an issue. And there's been some anecdotal evidence that even folks with legal status, there has been threats from employers to have their family members deported if there is retaliation. And all of these things play into chronic psychological stress. So chronic psychological stress, if you're working with an immigrant population, it's important to be aware of the various factors that might be explaining the psychological stress. So the psychological stress for folks, for immigrant population who without legal status, present in unique ways in terms of correlates of that psychological stress. And as I mentioned, legal status, which is attached to, being able to, feeling that you're unable to speak up against discrimination, against, inequity in wages, and so having that knowledge really will influence the strategies, your understanding how you work with this population, especially if you're working with this population in an aspect for whom you're trying to help them, provide psychological treatment, psychiatric treatment, provide or connecting them with social various resources. It's important to understand what are some factors that are really unique to the experiences of the immigrant population, also some subgroups. So culture sensitivity, lack of culture sensitivity in available care is also really an important structure, important factor that must be tackled if you're really going to look at inequities in healthcare and also mental health. So limitation of standard assessment batteries. As a clinical psychologist, I am very much aware, because of my training, because of my experience, I have been trained by folks that are multiculturally, I don't like to use the word competent, much more aware of various factors that are, or unique experiences that are relevant for the population that they work with. So assessments that a clinical assessment or batteries or measure, for example, that's assessing evidence of a certain disease, may not use language that's really appropriate for the target population. Meaning the standard language, a standard approach in which this assessment is done may not be capturing symptoms that is prevalent for that disease condition or for that psychiatric condition among this population, because they're not using the language that is familiar for the population. Let me give you an example that is relevant for psychiatric assessment. Major depression disorder, this is a disorder that is part of the hallmark symptoms include increased sadness, lack of decreased interest in previously enjoyed activities. So some of these, these hallmark symptoms, the standard battery is to ask people, include items that asking people, do you feel sad, and over the past, how sad you felt over the past 2 weeks or so. Most people, for some immigrant populations, what we were seeing, and I was working in Rhode Island in a community center during grad school, as a student clinician under the supervision of psychologists and psychiatrists, we were seeing that people were not endorsing these symptoms at all. But yet, the what was happening, they were still being impacted. Folks were having a really hard time getting their daily, functioning optimally, getting things done in their day-to-day environment while they had to go to work, but it just took so much out of them. What we saw that they were reporting more psychosomatic symptoms. So without understanding that certain population, Latina tend to report, or in other Caribbean population tend to report more psychosomatic, including some Asian population, more psychosomatic symptoms of major depression. And when you look at the medical history, people have had current recent physical that partial out any medical explanation. What we're seeing in terms, when you delve into an appropriate assessment, these symptoms, physical feeling fatigue all the time, mental slowness in terms of being able to stay on task, complete tasks, memory, all of these symptoms seems to be underlying some major depressive disorder. However, with the standard assessment that asks about symptoms that folks do not endorse, accordingly, a provider may miss or misdiagnose, may miss somebody who have depression because they don't endorse the typical standards symptoms for which that are covered by the particular assessment. So being aware of how culturally sensitive is an assessment in terms of assessing presenting symptoms, whether it is a medical symptom or psychiatric symptoms, understanding the cultural sensitivity, the psychometric validity, meaning that have these measures been developed, shown to be psychometrically supported among the target population. So attention to language is really important. Language proficiency. So having someone who is, part of the having providers who speak the language of the population is really important. Lack of using appropriate interpreters if you have providers who do not speak the native language of the immigrant population is really important. The issue that in my own work, I have a really huge problem to underserve the already underserved. I have worked in hospitals, especially during my graduate studies, where I was being given interpreters for certain patients, and I knew the interpreter did not appropriately communicate what I was saying. Because speaking another language does not necessarily make you a viable interpreter in terms of explaining psychological treatment or medical treatment, as well as its treatment protocol, because there are nuances that may not be captured. So having an interpreter that is trained with, in psychological and medical jargons, in medical protocol, psychiatric protocol, is really essential. So unfortunately, a lot of, low resource community health centers or hospitals may not have that. As a result, you may not be able to effectively treat patients. So you have patients that might be going untreated with conditions that are untreated that increase the risk for so many chronic diseases. Cultural explanation of diseases. So understanding that depending on certain cultures, how they explain the development of certain disease condition may vary. For example, working with the Haitian population, with women who are struggling with postpartum depression, we see that the biological mechanism, some subgroup of Haitian believe that postpartum come from which is a lack of production or of breast milk. This, and first of all, this is not people who are, undereducated, but even within high educated groups, there are some subgroups in which these are, cultural or things that are passed down from generation to generation that may go unchecked or, to further validity. They feel like the breast milk, for example, the malfunction of the breast milk, for some reason, it's impacting various brain structures that's leading to postpartum depression. Oftentimes, some subgroups will report even the taste of metal in their mouth. So understanding of that is really important. Well, if you're working with different groups, you're not going to be knowledgeable within every cultural background. But if you are working with a particular mob population more so than others, understanding the literature, being aware of these factors. Again, nobody is a repository of a pure culture. So I'm not saying these things are absolutely going to be evident for everybody that you work with, right? We're scientists. We look at trends and patterns. And you guys are developing scientists, depending on where you are going to go in your career, that the exposure to these type of literature is to make you aware of relevant factors that are important for culturally sensitive care. Understanding the role of acculturation. We know acculturation, in a way, is how it's defined, and it's defined in some of your module readings. Is basically how much internalization of the dominant culture that the group has, and compare, and there are different levels of acculturation. We know biculturalism identity is much more effective in terms of how people integrate with the whole population, meaning that they're not, because acculturation, if you fully integrate to the dominant culture, typically what happens is that you deny your own culture, right? You deny your own culture. Consequently, you may subscribe to negative stereotype of your cultural identity. So a bicultural identity, where you acknowledge the dominant culture, you also preserve your own culture, has shown to be, in some studies, protective of health and health outcome. However, the study is mixed in acculturation. But never, in acculturation, also another factor that's associated with it is, length of time in the host country. So being aware of the length of time of the host country. China makes sense, right? So somebody may have some issue with integration into a host country if they just came here as a refugee, right? Leaving their homeland because of some type of persecution, whether it's political or religious persecution, versus someone who's been here for 20 years. Even, time is a factor in terms of looking at level of acculturation, but even for folks who've been in the host country for many years, thinking about potential relevance of acculturation in terms of presenting conditions, particularly psychiatric conditions, are relevant. So knowledge of it is really important. According to your, some of your readings, and I believe was Young and Crooks, 2023, and other, Kremens et al. Also look at strategies for addressing health inequities among these populations. So, because we know that inequities are supported by multi-level structures, accordingly, solutions to potentially addressing them, decreasing them, and promoting health and mental health outcome also have to be at the multi-level, macro level, micro level, meso level. The importance of this, and I'm gonna. But the Kronos system is something I will talk about last. So the multi-level strategies for health promotion. we have to look at federal anti-immigration laws, for example, that really support inequities of health, that really support psychological stress, fear of being deported, fear of being separated from your family. Also at the state level, there's certain policies that have been enacted that have given, for example, law enforcement in certain states the free-for-all to stop people based on the fact they feel like they may look. I mean, they're not saying that, the laws are written that, stop people for being, because they appear to be illegal. I do not know what that means, or they appear to be of certain ethnicity, therefore increasing the likelihood of them being illegal. These state level, community level policies, or at times they're not written policies, they're just behaviors that are just supported or going unchecked. There have to be policy changes at the community level where folks feel like they are not supported or feel unwelcome, because there are a lot of various psychological distress that are associated with the fear of being stopped, the fear of being taken away or separated from your family if you're an immigrant person without legal status. The meso level, cultural factors that might be impacting how folks engage in care, understanding of diseases, how disease are developed, and these things also could be facilitators of engaging in healthcare if you're aware of them as a provider. How do you talk to your patients around beliefs around development of diseases, conditions, and maintenance of disease conditions? For example, in addition to culture, but also within a culture, having certain religion that is much more prevalent than others. For example, in the Haitian culture, supernatural forces might be one factor, how people explain development of disease condition. So understanding that within certain subgroups of the Hispanic population, religion also play a role of how people explain the development or maintenance of certain disease condition, including psychiatric conditions. The Corona system, why it's important, because there's certain major life events, social conditions or phenomena that are going on that may be impacting folks psychologically and physically. But think about the social unrest. Think about the social unrest in terms on Asian population, for example, during COVID. The attack, the physical attack, the verbal attacks on our immigrant brothers and sisters, where anti-immigrant sentiments. First of all, it didn't matter if these populations were born, raised here, or had legal status. The hateful comments was toward anybody that for whom who had these phenotypes. If you look Asian, oftentimes you were harassed because of anti-Asian sentiments tying being Asian to increased likelihood of transmitting the COVID-19, the corona virus, unfortunately. So thinking about various major events that may explain psychological distress, because we know psychological distress have an impact on us physically, it's really important to being able to effectively be receptive or address the needs of certain populations. So recap, ethnicity and immigration interact in terms of health disparities with some immigrant population. Chronic disease conditions impact these population are associated with similar determinants of health that we've shown across this other population. However, they may present in very unique experiences for immigrant subgroups. For some immigrant subgroups, the multi-level strategies that really look at structures or factors or systems that are contributing or maintaining inequities are really important for intervention. Understanding the burden these factors, these systems, these structures have on immigrant health is really important. While we, changes at the federal level is essential. However, changes at any level is important because we want to make sure we reduce the burdens that these folks are often experiencing. Additional references on the topic, and I will see you in the next module. Have a good one.